Top Med Talk.
Today's Top Med Talk is about the COVID-19 crisis. This piece was recorded last year. However, we still believe it contains lots of useful information. Have a listen.
So one of our friends from Top Med Talk and TriPOM in the EbPOM world, we have Dr. Sam Bampo, who is a consultant in anesthesia and perioperative medicine at the University College Hospital there in London. Sam, thank you so much for agreeing to chat with us. You have brought some friends, so can you make some introductions for us?
I'm joined here in London by Nuala Lucas, who is a consultant anaesthetist at Northwick Park Hospital and also an executive committee member for the Obstetric Anaesthetists Association, and also Pat O'Brien, who's a consultant obstetrician at University College Hospital and also vice president of the Royal College of Obstetricians and Gynecologists. So the three of us are here in London. Happy to chat to you today.
Nuala, can you give a little bit of background about your practice, where you're from, and kind of what you've been dealing with here in the last several months?
Well, I work at Northwick Park, a busy district general hospital based in North London. We do a lot of acute medical and surgical work on the general side, and we've also got a very busy labour ward. We do between 5,500 deliveries a year. My hospital's had a big hit from COVID on the general side, and as you've correctly pointed out, we've had to keep going on the obstetric side, with a mixture of the normal work, trying to get everyone through safely, and of course some obstetric patients whose obstetric pathways have been complicated by COVID disease. So there's been various challenges over the last month. I think we're starting to quiet down now a little bit. We're definitely having a bit of a trough from COVID disease. We're trying to rebuild a little bit now and to take stock of what's happened and look to try to rebuild and plan for the next wave.
I live relatively close to your hospital in the west of London, and I think that one of the real sort of things that woke us up, shook us hard in London, is when we heard that your hospital was starting to be overwhelmed. As one of the first places we heard that this sort of, wow, this is as real as we've been told it is, and it's happening very, very quickly. Are there any theories on that?
Our particular demographic, I think, in northwest London is a very densely populated area. It's a very diverse area, lots of different ethnic minorities, from a very international area. And I think both of those factors probably contributed to the hit we had, certainly initially. I mean, I think there'll be a lot of reflection and evaluation as to why certain places were hit harder than others. But I suspect those are the biggest underlying factors for Northwick Park, our density.
But I hope from the general COVID challenge perspective, I feel as though we've worked fairly effectively together in London and supported each other. And I hope it feels like that from your end. It certainly feels like that from our end at UCH.
Yeah, we've had an incredible number of intubated patients. And I think we've only managed to care for all of those patients, firstly because we expanded our ITU, but I think we've had huge support from across London accepting intubated patients for transfer. And I think myself and all my colleagues are enormously grateful to intensive cares around London who really stepped in that first week, 10 days in particular, when it hadn't quite arrived for everyone else. And the support we got, people coming to take patients and transfer them, was absolutely invaluable. That's been a huge factor. At one stage, the Nightingale Hospital that was built was all Northwick Park patients. It was like the outpost of Northwick Park. They had a few patients from elsewhere eventually, but at one stage we were the Nightingale Northwick.
Pat, can you tell us a little bit about yourself and your background and what your experience has been over the last several months?
I work in University College Hospitals, right in the centre of London, and we've been fairly busy. From the maternity point of view, we've been fairly busy. Obviously, our intensive care has been extremely busy, so our anaesthetic colleagues have really taken a hit. But the maternity unit, of course, there's only the same number of pregnant women coming through. So where we've taken a hit really is in terms of staffing. So doctors and midwives off sickness or self-isolation, or being moved sideways into support medical wards or intensive care and so on. So not too bad. And then ironically enough, because we're right in the centre of London, a reasonable number of the women that we look after and help to give birth to live in the peripheries, live outside London, but commute into work in the centre of London. And because, of course, they're not travelling to work anymore, strangely, our labour ward is a little bit less busy than before. So fewer staff, slightly fewer women, means slightly busier than usual, but not too bad.
Have you been dealing with quite a bit of patients that are coming in that are COVID positive for the mothers?
Well, reasonable. We've had a total of around 20 positive women over the last few weeks. All mothers absolutely fine, all babies absolutely fine. But bear in mind that in this country, until now, really, very few people not in hospital are being tested. Nor was it routine to test all patients. And that's just beginning to start off in most hospitals right now. It's entirely possible that people without symptoms coming through the hospital, we were completely unaware that they were positive until right now.
Could you just clarify for us, when you say that number of women, were they symptomatic women who were therefore tested? Is that the thing that we're differentiating here?
Indeed. So symptomatic women only. Now, I'm sure we could move on to the study from New York about asymptomatic pregnant women, and we've replicated something similar here. A study from New York, just a relatively small number of women, but it sort of tested serially women who came into hospital, symptomatic, asymptomatic, whatsoever. And in rough figures, about 85% tested negative, about 15% tested positive. And of those 15, roughly 13.5% asymptomatic and 1.5% symptomatic. So that was a real eye-opener, and I think changed practice and the way we viewed pregnant women coming through our labour wards and PPE and so on right across the world. And we've replicated that in a small study here in a private maternity hospital that I work in, and the total number testing positive among pregnant women was around 9%. But again, the ratio of asymptomatic to symptomatic was the same.
Pat, one of the great ongoing debates amongst the scientific community, and of which I'm far from an expert in it, is whether the symptomatic and asymptomatic represents in some way viral replication, non-viral replication, and therefore risk of transmission. I think we should err on the side of caution as a default mode till we know more. But what are the current feeling in your community about that?
Erring on the side of caution, really, and people are, when that study was published from New York, most staff felt that means that we should be wearing the PPE when we have any contact with any patients and with our colleagues, our staff colleagues who are asymptomatic as well. It kind of makes sense that if somebody is asymptomatic and therefore by definition not coughing and sneezing, that the risk of transmission may well be less and their viral load may be less if they're asymptomatic. But that's not necessarily the case, and you know as well as I do, there have been studies showing that when people are just talking normally in conversation with their colleagues, then there is a risk of spread even in that situation.
As we all know, well, I'm guessing we all know, in any normal pregnancy, there's a lot going on. If you see what I mean, there's a lot. Those of us who
know that more
it's
than
a dim,
others,
distant past. Well, we all know what we're getting at here. There's a lot of opportunities for spreading stuff.
Yeah,
master of the understatement with a lot going on there.
Of course, there's an ongoing risk to maternity healthcare workers as well. You know, antenatal care doesn't stop in the face of a COVID pandemic. Our pregnant population still have to come in and have contact with healthcare workers in maternity at several touch points during pregnancy and, of course, throughout their peripartum period. And so at UCLH, we've had about 20 patients who've come through who've tested positive. We've had about 100 patients come through who have been suspected, so symptomatic, and being treated as though they're positive until a negative test result has come through. But of course, there's this population of asymptomatic patients coming through who are in contact with all of us. And although a lot of our care is not aerosol generating, with obstetric peripartum care, there's always a risk that you need to find yourself in an aerosol generating procedure having to deliver a general anaesthetic very rapidly. And so really we've had to build systems from scratch to really try and accommodate and anticipate these asymptomatic women coming through. And at UCLH, essentially now we're using contact precautions for all patients. Most emergency cases that are going to theatre, even patients who are not testing positive, we are taking precautions of full PPE just in case we have to sort of perform aerosol generating procedures. So we've really had to think about this carefully and think about how we can minimise that risk for those of us working with these patients, looking after these patients.
Nuala, what about at your facility? I mean, you guys are doing a ton of procedures, and you know we know that there's been issues with PPE and things like that. So how have you dealt with that?
One of the difficulties with labour ward is that labour wards are often geographically remote within hospitals, and I think that geographical remoteness often extends to other working practices, knowledges. You're sometimes slightly behind what's going on in the main hospital. And certainly, you know, in my unit, it was on the labour ward, we weren't slow, but it was just much more difficult to get everyone on board with embracing PPE practices, donning and doffing, you know, which patients, which situations. And I think some of this, of course, wasn't helped by a lack of clarity over what type of PPE in what situation. And there was, in obstetrics, as I think in lots of areas of clinical practice, there was a huge debate about what aspects of obstetric care were aerosol generating. So, if you think about the first stage of labour, a woman who's hyperventilating because of pain, on the surface of it, that would seem like an aerosol generating procedure, aerosol generating step state, but huffing and puffing. But actually it hasn't been deemed to be aerosol generating. And similarly, the second and third stage. And I think internationally there was conflicting evidence. Certainly in Australia, some of the advice that came from the Australian Anaesthetic College suggested that the second and third stages of labour were aerosol generating, and that wasn't consistent with advice coming from other areas of the world. So I think a lack of clarity about what were aerosol generating, what was droplet precautions, that didn't help. And I think in the UK, there's been an underlying anxiety about have the recommendations for PPE been made, because there's a shortage of PPE. So we're trying to conserve it. So I think clinical staff didn't have the confidence sometimes in some of the recommendations. And I think all of those factors conspired initially to make it difficult to have a consistent approach. But a month feels like a long time. But I think certainly over the last 2 to 3 weeks, when the most recent advice came from Public Health England, which was about 2 weeks ago now, I think really there's been a much more consistent approach on our labour ward. People are starting to get more confident about using it, about how important it is, not just in what you wear, but how to doff it correctly. So I think we were, I don't want to say slow off the mark, but it was difficult to get everyone on board. But I feel much more confident that if the second wave comes, we'll be able to step up to the mark much more quickly and use PPE in a more consistent, standardised way.
As we've restarted elective major surgery, one of the ongoing debates when we look at the literature is we see that there are reports of virus coming out, or the viral code being identified in urine, maybe weeks after you've had COVID-19 positive throat swabs, and then in feces maybe up to a month or so afterwards. And then the debate is that viral code that's there, or is that something that could make someone sick? Where do you stand on that, Pat? Because that's getting really complicated then.
It's a very interesting question. And clearly the data are emerging, and we're still in the early stages of understanding this virus completely. There was a very good paper from Germany, I think it was, published in Nature or Nature Medicine, which looked at, in great detail, just a small number of patients, I think it was 9, and looked at them in great detail, looked at just about every bodily fluid you could think of, and looking at RNA and live virus. And the conclusion was essentially that even though from many sources, in particular nasopharyngeal swabs, you could continue to identify RNA for several weeks after symptoms finished. But by and large, it was very hard to culture live virus or identify shedding of live virus more than 7 or 8 days after the onset of symptoms. So that looks reasonably good data to me, but only small numbers, as I say.
And I think our observations we've seen so far is we've seen a lot more people come through with support that being likely. But it's interesting, you look at the WHO guidance, it still says we definitely know we don't know, which is one of those hard things to have. But we know that with confidence. We know we don't know with absolute confidence, which is hard to do guidance for.
Let me ask you guys, from the perspective at UCLH and Nuala, your hospital, do you feel that there has been transmission to healthcare workers? So you have these patients, known COVID mothers coming in. Have you had a lot of healthcare workers affected? More of a general statement there in London.
It's difficult to know because there are lots of exposures to the staff, not just on the maternity. We have, at the beginning of the outbreak at UCLH, the anaesthetic department was hit quite hard. We had quite a few people who went off, who were unwell and subsequently tested positive for COVID-19. As part of the work that we've done at UCLH recently, we screened, or a clinical testing program was launched that screened a proportion of staff, just as a quick sort of cross-sectional study. And that found that about 3.5% of the maternity staff, so that's obstetricians, anaesthetists, midwives, tested positive for COVID-19 and were asymptomatic. So there certainly is COVID-19 amongst the staff and probably being spread by staff to staff within the labour ward. So yes, it is there amongst us.
And one of the things we noticed just a couple of days ago is that staff, midwives, doctors going into the room to be with a pregnant woman were putting on all the correct gear. and then would come out during their quiet times and sit around a coffee desk, 10 people within close proximity, sort of chatting away for an hour on end. There's this kind of disconnect between, seeing patients as a risk and your colleagues as not a risk. So in fact, in the most recent update of our guidance from the Royal College of Obstetricians, we've added that in, remember that your staff could well be a risk to your health as well.
And one of the things that we've had that is worrying for staff is that we've had a lot of patients who have come in and had routine peripartum care and been taken to theatre or have been looked after by midwives, and then subsequently develop a temperature in their immediate postnatal period and then test positive. And of course, in the period before we adopted almost universal precautions, these women were being looked after by health staff who were unaware of their sort of infected status and were, I suppose, open to risk themselves. So there certainly was some anxiety earlier in the current outbreak. But now that there is more universally applied personal protective equipment in the labour ward environment, certainly I think it was about 3 weeks ago at UCLH, we sort of said at the very minimum we need to have droplet precautions for all encounters with patients. That's eased the anxiety and built a bit of confidence amongst us.
I just would endorse what Pat and Sam said. I think certainly in the initial phase, we saw a lot of our colleagues picking it up and being off for a period, but in the latter phases, it's much better. But I think that data from Wuhan does suggest that a significant proportion of COVID infections were nosocomial. But I think just in mitigation and what Pat and Sam have said, I think that if you think about the culture change that hospitals across the board have had to undergo in the last month, just embracing the challenge of COVID, I think people have done really well. I mean, it really is only, 5 weeks in, and people are applying PPE, they're not getting too close to their colleagues. I think we're there now, and I think to have done that in a month, 5 weeks is pretty good overall, and we're certainly ready for the next round with COVID-19.
Can I push us on, if I may, from the mother to baby question? And that is, does the route of delivery make any difference to that story? And is there any suggestion there's a risk of baby to staff and baby to baby, which is now getting quite complicated, or is everyone in play? That's one for you, Pat, I'm guessing.
No, we don't know, again, is the short answer. There's some studies coming out of China especially that have identified that around 9 or 10% of newborn babies have tested positive. So when the woman had the infection at the time of birth, that the babies have tested positive. But many of those babies were not tested until 2-3 days after birth, so it's hard to know whether they were infected before birth or after. Now, many of those women in China have been delivered by cesarean section, often before labour, often before the waters have broken. So, and then separated, mother and baby separated at birth. So kind of suggestive that infection took place before the birth. And then also perhaps slightly more convincing evidence, but very small numbers of babies who had cord blood or their blood taken within a few hours of birth, testing positive for IgM, anti-COVID IgM, which an IgM does not cross the placenta from mother to baby. So it looks like the answer is yes. There probably is the possibility of vertical transmission from mother to baby before the birth. But all of those babies have been absolutely fine. No detectable illness as a result of the COVID infection. And most of them would not have been tested were it not for the fact that their mother was positive. Do we know if the type of delivery affects the risk of transmission? We don't. I mean, we know there are some other types of infection that can be transmitted from mother to baby during a vaginal birth, like HIV. Is the obvious one, for example. But we don't have enough data to say that that's the case here. In the early days, all the Chinese data, almost all the data, were related to women delivering by cesarean section because they took the view early on it is safer to deliver by cesarean section in order to protect the baby from infection. But there really aren't the data to back that up. And particularly if you consider that even if there is infection during the birth process, the infection, the illness in the babies seems to be pretty minimal.
Nuala, you pointed to the fact that so much has changed in the last month and a half. Can you speak specifically about how the labor wards are running and, how has this affected, analgesia and anesthesia for these cases? Are you doing more C-sections because of these types of things?
I think labor wards have worked really hard to keep things as normal. And the other thing that we've really had to work hard to keep on the radar at all times is that we're in a really COVID-centric world. But other obstetric problems are much more likely, obstetric hemorrhage, preeclampsia, those sorts of things. And, my concern at the beginning was that intubating all of the COVID patients and rising to the challenge of that, we were going to forget about the woman who was having a postpartum hemorrhage in room 3. So in terms of labour, I would say most things have continued as normal in terms of the provision of labour epidural analgesia, cesarean section anaesthesia. We try to, when we've been concerned about COVID infection, we've tried to encourage women to have epidural analgesia so that if they do require an intrapartum cesarean section, we can extend that epidural and avoid giving them a GA because that's aerosol generating. The biggest change has been, I think, just the donning and doffing stations. And I would say the human factors elements of it, managing colleagues, midwifery, anxiety about caring for these patients. What do I need to do differently? And I think anxiety about being exposed to COVID infection. So I think mostly things have continued normally, and we've just worked hard to try and minimise missing out other important problems. There's a really good study published just after the Ebola crisis from Sierra Leone about 3 years ago. I think it was published in the BMJ Open, and those authors demonstrated that in Sierra Leone at that time, there was a 34% increase in non-COVID related maternal mortality, because women weren't attending for antenatal care, they weren't attending for postnatal care, and they certainly didn't want to come into hospital and have their babies. They were having babies in non-healthcare environment settings. And we were really keen not to frighten women away from having their babies in hospital. There was a real anxiety that women might start free birthing or have it not coming in and then not getting the care and attention they needed. And I think, it's really important that we don't see an increase in maternal mortality after this COVID crisis.
Can you speak to specifically with family members and having family members present, and how was that affected during all of this?
At the moment, most maternity units in the United Kingdom are allowing the partner to be with the woman during labour, during birth, during cesarean section, but then asking them to leave the hospital fairly soon after the birth because they don't want partners or other visitors going to the postnatal wards where there are by and large 4-bedded bays or 6-bedded bays with new mothers and new babies. So the risk of infection would be significant perhaps. There are some hospitals, private maternity hospitals, which have the luxury of having all single rooms, are allowing the partner to come and stay postnatally as well, but no other visitors, no children. So it's trying to basically, the principle is trying to minimise footfall in maternity units. There were some hospitals initially, I think, were a bit extreme and said that the partners couldn't be there even with the birth. And there was a huge backlash, I think, understandably against that. And the Royal College of Obstetricians and Royal College of Midwives came out with a joint statement, and Royal College of Anaesthetists. We got together and we came out with a joint statement pretty rapidly saying, look, we understand the motivation behind this, but it is terrible to think of a poor woman going through labour, vaginal birth, cesarean section on her own without the support of her partner. So I don't think there are any units imposing that right now.
I'm aware of a couple of hospitals, and my own included, who were initially very anxious about having partners, but all that we saw happening was those women turning up at other units to have their babies, potentially overloading other units. It's a hugely emotive issue because childbirth is not it's not a disease, it's a physiological process, and there's lots of really good evidence that having a birthing partner with you can improve outcomes. This is in the context of patients who were really sick and potentially dying from COVID infection, not being allowed to have a relative with them. So it was hugely emotive, but I feel that we're in a good place now. And the anaesthetists, when we're doing caesarean sections, we've had to be a bit creative about making space at the head end of the table for the dad so that we're not all crowded in together. So arranging drip stands and social distancing as much as possible. But a bit of creative thinking, and it was possible.
Complicated area about the potentially high-risk partner. If there's an older partner, perhaps an obese partner, perhaps a pre-diabetic partner, do you ever have to counsel the partner about the risks?
Not now. I think they're all pretty much aware of the risks at this stage. Maybe a couple of weeks ago, yes, but I think people who have comorbidities than the partner are acutely aware of the risks themselves nowadays. But they take that decision themselves, and as you imply, it's the risk to themselves. And if being present for the birth of their child with their partner outweighs that, then fair enough.
Talking about all these things also makes you think about throughput and trying to get the mothers out in a more expedited time frame. Have you noticed that? Are you still keeping, if their partner can't be there with them? I mean, that is still a huge load to carry if you're in the hospital for, 2 or 3 days post-birth.
At UCLH, we have tried, as Pat alluded to make sure our partners are leaving in a sort of expedited fashion. There has been a move, or certainly people have been discussing certain things like same-day discharge after elective cesarean section, but that's slightly untested ground, isn't it, in the UK? And I think that throws up its own concerns, and we really have to try and find the right balance. The reality is there aren't really any robust data to support what we should be doing, so it's still slightly uncharted territory.
So enhanced recovery in OBS is a big thing for us, as it is in most areas of perioperative medicine, and I think there is lots and lots of good data that suggests that day one, 24 hours post-cesarean section discharge is safe. But I think because there's really very little data to support same-day discharge, and there's a few things that need to be done. This is in a time when community services for postnatal patients are probably depleted. So you're potentially sending a woman at home early without any community backup, and then you're risking having readmissions, which could cause more problems in the long run. So I think the added advantage of keeping a woman just on that first post-op night, sort things out properly so it's a safe discharge, you're not going to risk readmission, I think I would stick with that, and that would be my advice if I'm asked.
Because I would guess, as you were saying, Nuala, the community is probably creaking a little bit at the moment from that lot of pressure on them as well.
Yeah, absolutely. I think GP services, community health centres, all of those sorts of things, the same backup is not there, and those healthcare workers, they have the same difficulties and anxieties and problems with PPE that people have experienced in hospital. So I think you ideally want to minimise, we're all supposed to be self-isolating, minimise unnecessary contacts. If we can sort things out properly on the postnatal wards, get a clean discharge, a woman is safe and happy and no chance or minimal chance of readmission, I think that's probably the best strategy.
Many of us often turn to our parents, grandparents to help under these terms, and the message is, hang on a second, should you come or should you stay away? It's complicated.
On social media, there's been some really heartbreaking and poignant pictures of new babies meeting various family members through windows. I've seen lots of pictures of grandparents looking at their new grandchild through windows, and there was a great picture from Australia of a woman showing a new baby to her older siblings and the husband, and I thought, crikey, the human spirit will always prevail, though, I think.
Yeah, I was going to say, too, that for a first-time mom versus a mother of multiple kids, it's different, too. You don't want to send a first-time mom on day one. From experience, I can say that. Well, guys, thank you so much for joining us. Were there any other points that you think would be beneficial to share through your experiences with other people listening from across the world? Yes, Pat?
So with regard to antenatal care, the model has changed dramatically, as you can imagine. So the usual frequency of visits is about every 4 weeks at the start, then every 2 weeks, and then every week towards the end. And many of those consultations are just conversations. There's no scan, there's no blood tests, and so on. So clearly all of those have changed over to telephone or video conference. And that's a real benefit to pregnant women, I think, not having to travel to the hospital or organise childcare and so on. The main reason that the frequency of visits increases towards the end is to check blood pressure and test urine, looking out for preeclampsia, which is commoner towards the end of pregnancy. And is a bit unusual in the sense that with most problems in pregnancy, women would come to us, so if there's pain or bleeding or whatever. Whereas with preeclampsia, often blood pressure can be quite high and the woman feels absolutely fine. So we have to proactively check it regularly, more frequently towards the end. So having moved up most of these visits to telephone consultations, we're rolling out a sort of a home blood pressure monitoring thing, which will be piloted for the last couple of years. But women, for example, will either buy or be given by the NHS a little blood pressure monitor. They check their blood pressure once or twice a day at home. They will often have a chart to refer to or a mobile phone app that will tell them, that's fine, or recheck it in an hour or go to the hospital. So that's a real advance. And I think when all of this COVID eases off, many of these advances will persist in antenatal care particularly.
Just on a slightly separate note, I think throughout this conversation we've alluded to the fact that as data emerge about the effects of COVID in pregnancy, that's guiding our practice, and guidance changes frequently as new data emerge. And a number of registries have been set up that are allowing us to collect data about the course of COVID-19 in pregnancy, but also importantly, the effects, for example, within healthcare workers. So I would urge people who work in maternity services to sign up to these registries and enter their data. Our healthcare worker registry is obscovid.org, so that's obscovid.org. And we've had hundreds of people from about 15 countries around the world sign up and enter data about their encounters with patients. And that's allowing us to collect demographics and risk factors. And as these data come in, we can then better understand how this disease affects patients, how it affects healthcare workers in maternity, and really will guide, how we deal with this going forward. So final word for me would be to urge healthcare workers in maternity to seek out these registries and enter their data when they can, because that's really helpful for us.
The future of obstetrics and the future of medicine will absolutely change because of this. And Pat, as you alluded to, hopefully for the better.
Top Med Talk.
Guys, thank you so much for joining us. I can't tell you how much this, I'm sure, is very useful to everyone listening out there. So thank you. Stay safe in your own practices. Stay well. And thank you for listening to Top Med Talk. If you want to find more conversations like this, you can go find us on topmedtalk.com. We're on social media too. Your favorite platforms, LinkedIn, Facebook, Twitter. We are there. To everyone listening, stay safe, stay well. We're all in this together. We're going to get through it. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.